All right, thank you everybody for having just this little short break just to get us back on track again. So I'm pleased to welcome Dr. Helmut Renke. Dr. Renke is a professor of pathology at Harvard Medical School and has been the director of renal pathology at the Brigham and Women's Hospital for many years. He is an expert in pathology. He has taught me more than I could ever possibly tell you. And I always look forward to his lectures, both in this course and in our pathophysiology courses at the medical school every year. He is a wonderful teacher, a wonderful colleague, and really happy to have him back again to speak with us this morning.
Thank you, Geroid. Well, I will refer this morning, my topic is the nephritic conditions. I have no relevant disclosures. I will review the patterns of injury associated with the hematuric conditions and the nephritic syndrome and discuss the pathophysiology and differential diagnosis of these patterns of injury. I will heavily rely, of course, on images because I think it is important for you, the clinical nephrologist, to get a different view of the diseases, not only the clinical aspect that is important for you when you hear or when you read the diagnosis, to have a vivid image of the patterns of injury. As you know, the cardinal signs are proteinuria, hematuria, and loss of GFR. And obviously, in the nephrotic syndrome, which my colleague Dr. Wines is going to deal with, the proteinuria is the relevant issue. In our nephritic conditions, the hematuria is clinically important, and of course, it is recognized either by dipstick or by looking at the sediment frequently with dysmorphic red cells and red cell casts. And the degree of GFR loss varies depending on the various conditions. During the acute nephritic syndrome, you have very sudden loss of GFR, whereas in the rapidly progressive GN, the loss is over several days, if not weeks. So even though it's called rapidly progressive, it is slower in progression than the acute nephritic syndrome, which presents from one day to another. On the other hand, the asymptomatic hematuria is usually much more insidious and therefore not often clinically not apparent. So the critical aspect is, of course, the glomerulus. The glomerulus is the site, in this case, of the injury, and it's not the podocyte, which is responsible for the proteinuria, but rather the endothelial cell. And the endothelial cell is as highly differentiated in the glomerular capillaries as the podocyte is. Namely, we have open fenestra, and you can see the open fenestra here on the transmission electron micrograph. This is quite unique to this microcirculation, and it's a unique adaptations to, of course, to facilitate and to increase the convective flow across the capillary wall, given the imbalance of Starling forces that get established. So the endothelial cell is the target in most of the nephritic conditions. The epithelial cell only gets, if you will, incidental or collateral damage, and therefore the proteinuria often is minimal. There's always proteinuria because there's always abnormalities in the hydrostatic pressure, and therefore you will always get some leak of protein, even when the podocyte is not primarily the target, but rather the endothelial cell in these conditions. And therefore, when you see a patient where the proteinuria is the dominant feature, think of a podocyte disease. When you have a patient with an active sediment, think of an inflammatory condition, and therefore on the proximal layers of the capillary wall. The other aspect I wanted to emphasize up front is that inflammation and thrombosis go hand in hand. If you injure the endothelium just a bit, you have inflammation. If the endothelial cell is massively involved and you lose thromboresistance, thrombosis will occur. Unfortunately, most patients that present with this type of damage will have overlap features of nephritis or glomerulitis, if you want, as well as of TMA, thrombotic microangiopathy. And very often it's very difficult to differentiate between these two two basic phenomena because they are often simultaneously present in the same patient. And this is highlighted in this cartoon here, if you want, in which on the left-hand side you have the active inflammatory lesions geared or directed by the endothelial damage. And on the other hand, you can have, in a more severe form of injury, you can have fibrin thrombi, platelet aggregated and fibrin thrombi. So the glomerulitis is the relevant feature responsible ultimately for hematuria. There are also patients that have fragile basement membranes, like collagen 4 defects. The Alport syndrome is a classic example of that, in which the capillaries are fragile. And though under normal circumstances, you have breaks in the capillaries that result in red cells contaminating the ultrafiltrate and eventually the urine. And therefore, when you have a patient with hematuria, think of these two basic abnormalities, the glomerulitis, and we will go into detail into the various mechanisms of that, and the capillary fragility, namely thin basement membrane glomerulopathy, and the more severe form, which is the conventional Alport syndrome, if you want, or hereditary nephritis. The presentation can be very acute from one day to another, in which case usually the pattern that is associated with that kind of nephritic syndrome is the diffuse proliferative glomerulonephritis. With time, and when the injury persists, the patient will slowly develop a membranoproliferative pattern of injury, which is a little later phase, but basically of the same pathophysiology. Here you have a case of what people used to call diffuse proliferative GN, which these days we prefer to call with diffuse endocapillary hypercellularity. You notice that the capillaries are all occluded. There are no open spaces here. Many of the cells are neutrophils, and you can recognize them by the nucleus, but many of them are mononuclear cells, as you can see. As a matter of fact, the majority of mononuclear cells. This varies from time to time, from one patient to another, depending on the suddenness of the onset of the nephritic syndrome. Here you have a classic example of diffuse proliferative or diffuse hypercellularity with neutrophils. There is a few basic deposits of IgG, much more complement is present, and then by electron microscopy, in cases of post-streptococcal GN, you see the classic subepithelial humps. Notice here a neutrophil sitting right on the basement membrane. The endothelial cell has been stripped away completely because the initial immune complexes were not present in the epithelium, but rather right next to the endothelium, and that's why you have actually an active inflammation with neutrophil infiltration. Very important these days, we see relatively few cases of post-streptococcal GN. Most often, the infection-associated GNs are in patients with diabetes, with fat ulcers, or with osteomyelitis. And in that case, the dominant immunoglobulin is not the IgG, but the IgA. And therefore, this can be confused with IgA nephropathy. Notice here again, because there is diffuse infiltration of neutrophils, there is subendothelial immune complex formation next to the endothelium, which is the target injury. Notice that the porocytes are reasonably well preserved with only very focal areas of effacement in a case like this, and in this case, no subepithelial immune deposits at all, which are more characteristic for the post-streptococcal GN. Here you have another case of a hepatitis C-associated acute GN. Most often these patients present more chronically, but occasionally you have patients that present very acutely, and you have a diffuse endocapillary hypercellularity. In this case, the deposits are IgM dominant because very often these patients have a mixed cryoglobulinemia, even at the very beginning of the hepatitis C infection. And here you have the deposits that have the characteristics of having a very sharp outline on the outside, and you can see they are delineated very clearly on the outside, and that's because the electron microscopy shows you that the deposits are leaning against the basement membrane, and therefore they have nowhere to go beyond the inner aspect of the capillary wall in the subendothelial space. Notice also there are some substructures here, organized substructures, and that is because the IgM is usually monoclonal in these mixed cryoglobulinemia cases, the IgG being polyclonal. You can also demonstrate, of course, the IgG in these cases together with the IgM. Rarer instances of infection include even parasitic infection. This is a patient that had strongyloidiasis acquired in a trip to Africa. And again, you see the very dominant IgG now leaning against the basement membrane, the electron-dense deposits, and the diffuse proliferative pattern and diffuse endocapillary hypercellularity in this patient. Now, together with the infection-associated GNs, which you can see includes all kinds of viral diseases, bacterial diseases, as well as parasitic diseases, you have the autoimmune diseases. And the most important, of course, in the group of autoimmune disease is diffuse lupus nephritis, class 4 in this case, because you have diffuse endocapillary hypercellularity. Lots of deposits in this case. In this case, you frequently have also IgG, IgA, and IgM, in addition to C3 and C1q, what people have called the full house immunofluorescence microscopy, which, by the way, is not unique to lupus. Also, in many cases of infection-associated GN, especially with staphylococcal infections, you can have a full house without it necessarily meaning that the patient has to have a systemic lupus erythematosus. Also, in this case, when you have active inflammation, notice the subendothelial deposits, some are very often to the point of developing wire loops when the entire circle of the capillary is involved by immune. Notice here also the adherent inflammatory cells close to the damaged endothelium here, a classic picture of this. All this is frequently due to the paradigm of entrapment of preformed immune complexes, and the paradigm that these diseases follow is the so-called serum sickness, which was a very interesting and the first model of experimental immune complex disease in the kidney. There are numerous aspects of the antigen of the bacterial or viruses that are determined where the deposits will form. Usually large circulating immune complexes get entrapped in the subendothelial space in the proximal layers, and hence the injury to the endothelium with the resultant active inflammation and potentially thrombosis. This is synthesized very nicely in a relatively recent paper by Nasser, but there are some subsequent iterations of this in other journals in which one emphasizes that at the beginning you have antigens in circulation, eventually antibodies come in, and these immune complexes move mostly to the mesangial and to the subendothelial space, and then later on you have the active inflammation that occurs in these patients. Many host factors play a role, including genetic susceptibilities, abnormalities of the alternative pathway, contribute to the severity of this disease. And as I mentioned to you before, sometimes, especially when patients have vulnerabilities in terms of the procoagulant states, very often you can get a very important TMA as part of this acute event. Here's a summary of the more frequent conditions: viral diseases, bacterial infections, as we already discussed, protozoal infection, and other infections such as borreliosis, as I will show you in a second. Not to forget that the other group of diseases, also very prevalent, of course, are the autoimmune diseases, not just limited to SLE, but patients with Sjögren's can have this pattern of injury. Occasionally, patients patient with rheumatoid arthritis. And don't forget that many of the autoimmune conditions have a lot of overlap. We artificially pigeonhole them into lupus or Sjogren's or rheumatoid arthritis, but very often, or even systemic sclerosis, but very often there is significant overlap between these various forms of autoimmune diseases. With time, these diseases, this pattern of injury of a diffuse endocapillary hypercellularity moves into the membranoproliferative pattern of injury. And there are two features here morphologically that are relevant. The hypercellularity of the glomerular tuft, mostly mononuclear cells, and the thickening of the capillary wall in a very unique pattern, namely with double contours, what people have called tramp tracks or double contours and so on and so forth. This is when the endothelial cell regenerates and forms a new basement membrane, and in between the two layers you have, as shown here, layers of electron-dense deposits, immune complexes in other words, sometimes also paraproteins, and interposition of cell fragments. Notice here the endothelial cell is displaced. It should be attached to the basement membrane here. It is displaced by the accumulation of this material in the subendothelial space, the cells and the cell projections and the electron-dense deposits. The endothelium is displaced and it generates, like all cells do, except for the circulating cells, it generates a new basement membrane that you have right here. So you have the new basement membrane and the old basement membrane up here, in between an empty space on silverstain or on PAS, and this space, of course, is occupied by the immune deposits and by cells. In the olden days, we classified this as idiopathic type 1 with subendothelial deposits, with very dense intramembranous deposits, also called dense deposit disease, or type 2, and type 3 with various subclasses, of course, with subepithelial deposits as well. This is completely obsolete. We should no longer consider this a disease entity. And I think anytime you call something idiopathic, it means that we are ignorant about the cause or the mechanism, at least. So I think this is an obsolete, old nomenclature that we should not use. It is a pattern of injury. The membranoproliferative GN is a pattern of injury, not necessarily a disease, as you will see. So the conditions that result in this membranoproliferative pattern with time is, of course, immune complex diseases, abnormalities of the complement protein, regulatory proteins need to be considered, thrombotic angiopathies, and most importantly, paraprotein deposition diseases. All of them can give you the membranoproliferative pattern of injury. And obviously, it is our intent usually on the biopsy to precisely tell you which of these four mechanisms are responsible for any given case of a patient with a membranoproliferative pattern of injury. Here you have a case with an immune complex disease, probably a chronic infection, a patient with IgG, C3, C1q, double contours, and hypercellularity. It fits the bill of membranoproliferative GN. When you see endoluminal large deposits, what people have called pseudothrombi, you frequently think of cryoglobulinemia, be it type 1 or in this case type 2, related to hepatitis C infection. These endocapillary immune complexes should not be confused with fibrin thrombi or platelet thrombi. These are protein thrombi, if you want. The immune complexes are unstable in the circulation, very often in the glomerular capillary circulation because of the hemoconcentration, and therefore you develop easily these aggregates inside the lumen of the capillary. This is a 57-year-old man with a history of Zika syndrome, now with several months of history of fatigue, and you can see a creatinine of 2.13 and an active sediment. The ANA is positive in a speckled pattern, and the antibodies against hepatitis C are negative. The ANCA is negative. Anti-Rho and La are all negative. And here you can see classically the endocapillary immune deposits or pseudothrombi, if you want, the proliferative pattern of injury, the IgM, the IgG, and kappa much stronger than lambda. So this patient has Sjogren's-like syndrome with mixed cryoglobulins. The IgM is probably monoclonal. Usually it's an IgM kappa, and not infrequently is the case that you can demonstrate the presence of a monoclonal band in these patients in the IgM region. And the IgG is usually polyclonal, and hence you have some lambda as well. Here you have the deposits mostly in the subendothelium, massive injury, of course, of the endothelium and active inflammation. And here you see the classic endoluminal pseudothrombi protein that very often have, again, this substructure, this organized substructure in little microtubular arrays, as you can see, that is a telltale for the participation of a monoclonal immunoglobulin. So this patient has Sjogren's syndrome associated with a mixed cryoglobulinemia. Not infrequently, these patients develop later on overt lymphomas, and therefore they need to get treated for that as well. Here's a classic example of a membranoproliferative pattern of injury in a patient that presented with a carditis also, and it eventually was traced back to Lyme disease, to borreliosis, and therefore here you have the classic subendothelial deposits and the very dominant IgG deposits in this case. So you have to think outside the box very often in these patients with very odd presentations, not infrequently. Like in the diffuse proliferative pattern of injury, also here you have to consider acute and chronic infections, and I mentioned a few of them. Hepatitis C is a classic one, but also these other odd infections like borreliosis. And of course, autoimmune diseases also fall into this category since they have mostly a more protracted course. Abnormalities of complement regulatory proteins are the new kid on the block, if you want, very important. And in this, we recognize or we have pigeonholed three conditions: dense deposit disease, glomerulonephritis C3, GNC3, and atypical HUS. As I mentioned to you already, there is a lot of overlap between these entities because the mechanism of injury is the same. It's an abnormality in the complement regulatory proteins, and therefore we don't know exactly what entices any given patient to present with dense deposit disease, with glomerulonephritis C3, or predominantly with an atypical HUS, if you want. So in this case, under normal circumstances, this convertase of the alternative pathway is normally active under normal circumstances, and there's constantly activation, if you want, of C3 that leads to a small level of C3A and C5A. These are the anaphylitoxins that induce the active inflammation, and the C5b29, the membrane attack complex, that injures the cells. So under normal circumstances, this convertase, this enzyme, is maintained in check by the circulating factor H, factor I, and the cell-bound CD46, and therefore you don't get excessive breakdown of C3. However, this is under normal circumstances, and you can have, of course, genetic abnormalities at this level in which this doesn't function well, or you have autoantibodies directed against these enzymes, if you want, that protect them from being degraded by the factor H and factor I, and therefore antibodies, but also monoclonal immunoglobulins can interfere with the degradation of this enzyme that then suffers a gain of function, and you have constant activation of C3, consumption of C3, elevated levels of the anaphylitoxins and of the membrane attack complex in the circulation, and of course low C3 in this case. So as you can see, there are acquired conditions and there are genetic conditions. In the older population, it is the acquired conditions that dominate the picture usually, whereas in the younger population, you often have to consider a potential for a genetic abnormality. These patients then present as as children or as young adults with the nephritic syndrome, usually triggered by an intercurrent infection or some other events in their life. There's always a trigger, not infrequently an infectious trigger, that takes this off this system. Here you have what results in this with a lot of complement deposits in the form of dense deposits. This is a classic dense deposit disease. In this particular patient, this patient had a circulating monoclonal immunoglobulin that was the culprit, if you want, or the cause of this form of injury. Here you have a case of a glomerulonephritis C3 or C3GN. The C3 dominates here. There is no kappa, no lambda, no immunoglobulin, but a massive membranoproliferative pattern of injury. Frequently, these patients have hump-like structures, and you can demonstrate very often in these patients, like in this case, a completely normal genetic panel for the complement systems, but these patients have very often an acquired condition. Here you have an 88-year-old man with recent onset of proteinuria, edema, and kidney failure. He has a circulating paraprotein. And as you can see, most of the capras are occluded by swollen cells. There is a lot of C3, no immunoglobulins. This patient doesn't have a monoclonal immunoglobulin deposition disease, but rather a C3-driven damage of the endothelium with some fibrin in the capillaries and double contours without electron-dense deposit. However, there is one hump-like deposit, and this is telling us that this particular form of TMA, if you want, is driven by the C3, in which case you often have mesangial densities as well as subepithelial humps. So this patient has a monoclonal gammopathy of renal significance, but without deposits of the monoclonal in the glomerular capillaries, but rather the consequence of this monoclonal interfering with the complement system and deposition of C3 with the endothelial damage that results in this pattern of injury. And you can see here, if you analyze the functional panel for complement activation, you can see that the alternative pathway is clearly, you have a low level of the activity because of consumption. The C3 level, the peptide that results from the activation is of course elevated. So, and you can see also here the level of BA factor B, the activated factor B is also elevated, and of course the soluble C5b29 is elevated, whereas the properdin is low because you have consumed properdin together with the C3, for which the alternative pathway hemolytic assay is positive in this case. As you can see here, if you break down the cases of C3 glomerulonephritis, this is courtesy from Dr. Smith from Iowa, you can see that the great majority of patients with C3GN have an immunologic cause, namely either a nephritic factor, an antibody against the convertase, and few of them have a genetic factor. Notice that many of them are unknown, and therefore I suspect that many of them have either other autoantibodies or, more importantly, they may have a paraprotein that may not be detected that gives you a C3GN. Not to forget that thrombotic angiopathies can also result in the membranoproliferative pattern of injury. And here you have a classic example of a membranoproliferative pattern with double contours, but no electron-dense deposits, with very severe onion skin lesions of the arterioles, and this is what gives this case away, and dull staining of fibrin along the capillaries. Many double contours have this. Many double contours in this case are due to endothelial injury, but without active inflammation classic thrombotic angiopathy. I believe this patient was a patient with an antiphospholipid antibody that had this very severe form of injury. Not infrequently, patients with these procoagulant states, antiphospholipid antibodies, and other genetic procoagulant states, as women present during pregnancy with eclampsia, and the eclampsia is basically a thrombotic angiopathy affecting not only the kidney but also to some extent the placenta. So the acute and chronic thrombotic angiopathies include the complement-mediated TMA, coagulation, metabolism, and therefore the differential diagnosis, which I'm not going to go into at this point, of the thrombotic angiopathies is rather complex and very much involved. The fourth mechanism by which you can get the double contours and the membranoproliferative pattern these days is very important, namely paraprotein deposition diseases. And here you have a case of a diffuse hypercellularity, endocapillary hypercellularity with double contours, lots of subendothelial deposits, but the deposits are positive only for kappa and IgG, but not for lambda. So the entire monoclonal IgG kappa is depositing in the subendothelium, resulting in active inflammation in this case. Not infrequently, one cannot detect the circulating paraprotein, and not even can you detect a clone of B cells or plasma cells in these patients, and therefore very often the kidney disease antedates the malignant lymphoproliferative disorder, sometimes by months and sometimes even by years. We demonstrate the monoclonality of this not only by the light chain, but also by the heavy chain. In this case, it is a gamma-3 that is depositing and not the other heavy chain of the immunoglobulin. So clearly a mononuclear, and very often these deposits have substructures. Here you can see this parallel line array. Sometimes they are microtubular. So often by electron microscopy, we have very unique patterns in which these immunoglobulins associate and precipitate down. Not to forget, not only do we see these conditions in multiple myeloma or as a consequence of multiple myeloma, but very often these patients have a lymphoproliferative disorder that can go from CLL, classic CLL, small cell lymphoma, follicular lymphoma, all the way to Waldenstrom's lymphoplasmacytic lymphoma. All of these patients can develop these complications of the paraprotein in the kidney. So the membranoproliferative pattern of injury can be broken down by morphology. If there are polyclonal IgG, C3, and C1q, we call it an immune complex disease. Infections, usually chronic infections and autoimmune diseases come to mind, in this case, lupus, Sjögren's, and others as well. When the immunoglobulin is monoclonal, either by light chain or by heavy chain, there could be also C3 and C1q activation. And then we think of a paraprotein deposition disease, and obviously the workup will include for lymphoproliferative disorder and plasma cell neoplasm, and then we call it a paraprotein deposition disease. When there are no immunoglobulins, only C3, we think of glomerulonephritis C3 or C3GN and dense deposit disease. And if there are no immunoglobulins, only some dull staining of fibrin, we think more of a chronic TMA giving you this pattern of injury. Now to the rapidly progressive glomerulonephritis. In this case, the loss of function is over several days and weeks. The patient has an active sediment. Usually there is no edema and no hypertension, as opposed to the acute nephritic syndrome, which frequently courses with edema as well as with hypertension. The two patterns that are most frequently seen in patients with a rapidly progressive GN are the focal necrotizing glomerulonephritis and the crescentic glomerulonephritis. And we distinguish type 1 with anti-GBM disease or linear staining of IgG, type 2, which is an immune complex disease, can happen in any immune complex disease, including IgA nephropathy. The type 2 can happen in lupus, of course, with crescents or with post-infectious GN as well. And the type 3, which is probably the most frequent one, pauci-immune, usually the expression in the kidney of a microscopic polyangiitis, sometimes with lung involvement and with what we then call a granulomatosis with polyangiitis, or when the patient has eosinophilia and asthma, we call it Church-Strauss syndrome sometimes. And not to forget, there are a number of drugs that can induce ANCA and can result in a crescentic GN, very often with a hint also at immune complexes, as I will show you in a second. Here you have a classic example of linear staining of IgG along the GBM with fibrin in the crescent with a focal necrotizing pattern and crescentic pattern in a patient with sudden onset of anti-GBM disease. This is probably one of the few emergencies that we also in renal pathology have, in which we have to convey the message very quickly so the patient can get treated and to prevent further complications, mostly in the lung. So the other mechanism, in addition to the anti-GBM disease, is of course an immune complex disease, either infection-related or autoimmune, and the pauci-immune ANCA-associated disease. Here you have an example of an immune complex disease in a patient with lupus, mostly mesangial deposits, but some crescents there with mesangial deposits, and therefore a very aggressive form, if you want, of lupus nephritis. Here you have an example of a pauci-immune polyangiitis with a crescentic GN, focal necrotizing, simplified here, but also with a vasculitis. This is a small vessel vasculitis with fibrinoid necrosis, no electron-dense deposits, in this case by electron microscopy. And as I mentioned to you before, very important these days is to consider a drug-induced ANCA in these cases. And very often patients with a drug-induced ANCA also have an immune complexes, ill-defined very often, because these drugs that cause the ANCA also tend to cause more systemic autoimmune phenomena. As a matter of fact, in the olden days, drug-induced lupus it was caused by exactly the same drugs that these days are associated with an ANCA, with a drug-induced ANCA disease. And when we have immune deposits in addition to a crescentic GN, we should think very often in these drugs. And here I have listed the most common one: hydralazine, propylthiouracil, minocycline, penicillamine. And not to forget cocaine. Cocaine is often admixed with levamisole and procainamide, and both these drugs have been known to induce vasculitis through an ANCA kind of mechanism. And therefore, when you see an immune complex disease and a crescentic GN, always think of a potential for a drug-induced injury. I'm not going to go through the mechanism of ANCA disease. It is somewhat controversial, but this is well described over the last, 30 or 40 years. Every few months we get a new iteration of this mechanism, which I think is probably incomplete. And finally, the asymptomatic hematuria and proteinuria, classically exemplified, of course, by a mesangial proliferative GN that not infrequently results from an IgA nephropathy, which is probably the most frequent cause of this pattern of injury in patients with asymptomatic hematuria and proteinuria. Patients with a previous post-infectious glomerulonephritis during the recovery phase can mimic this pattern of injury and this presentation as well. And obviously, patients with lupus class 2 will have very similar clinical as well as morphologic presentation, but some differences, of course, in the immunofluorescence microscopy. Here's the classic IgA nephropathy with very prominent mesangial deposits. The mesangium is a little expanded. The peripheral capillary wall are perfectly okay. You can see the interdigitating foot processes well maintained. A mesangial expansion with slight hypercellularity. Not infrequently can these patients, especially when they have an active disease, at the time of the biopsy, you can see a focal, proliferative, and even sometimes a crescentic pattern of injury. And that brings us to the evolution. And the evolution or the natural history of this is that you can have relatively benign conditions and you can have a rapidly progressive IgA nephropathy, very often with a crescentic manifestation on biopsy. And invariably, especially these patients with the more aggressive forms of IgA develop chronic kidney disease. So in IgA nephropathy, anything is really possible. Unusual presentations of IgA nephropathy include patients with gross hematuria and acute renal failure, probably from the red blood cells in the tubules, which can be associated with renal failure. IgA with a superimposed minimal change disease. We have seen one or two cases of that have the typical features of minimal change disease that Dr. Wines is going to discuss with you next. Patients IgA nephropathy with a superimposed membranous nephropathy, and you can see that the membranous, the peripheral capillary wall staining is for IgG, whereas the mesangial staining is for IgA in these cases. Very challenging for the pathologist, but not impossible with good technique to recognize both these different forms of immune complex in the same glomerulus. And finally, there are cases reported on IgA nephropathy that also develop an ANCA-associated lesion, and therefore the necrotizing and crescentic lesions can be attributed either to the IgA, which exists, or to the superimposed ANCA in these cases. I'm not going to go through the pathogenesis of the IgA nephropathy. Again, it involves different degrees of glycogenation of the IgA hinge region. Important is the Oxford classification. When you only have mesangial hypercellularity, this is expressed in its severity by an M1 or M2. The endocapillary hypercellularity is either absent or is present, and we mentioned that. The segmental sclerosis usually denotes already some chronic lesions, and therefore it's important to notice whether the patient has segmental sclerosis, which is usual segmental scarring. The degree of tubular atrophy in interstitial fibrosis is very important because the more IFTA you have, the more tubular atrophy and interstitial fibrosis, the worse is the prognosis, of course, because the patient has more advanced disease at the time of the biopsy. And the fifth element that we recognize for the Oxford classification is, of course, the presence or absence of cellular crescents. The higher the numbers in this, of course, the worse is the prognosis, and the more crescents you have, or the more focal necrotizing lesions you have, the more likely it is that the patient has a currently active disease that probably should be dealt with. And finally, not to forget that glomerulitis and the various forms of active inflammation are only part of the differential diagnosis of hematuria and proteinuria. Not infrequently do we find combinations of diseases, of course. The capillary fragility is frequently expressed morphologically by either thin basement membrane or the classic Alport syndrome. And obviously, Alport syndrome is a defect in collagen 4. And the collagen 4 has basically three important peptides with three different genes that encode for the three different type 4 collagens that are participating in the formation of the GBM. And therefore, any of these three genes can be abnormal. In a male with classic Alport syndrome, it is the X-linked alpha 5 type 4 collagen that is defective, whereas in the autosomal recessive, it is one of the 2 autosomal genes that is defective, and in thin basement membrane, it is a single gene that is defective, namely heterozygous defect of either the alpha 5 or the alpha 3 or the alpha 4. These 3 peptides come together in the adult GBM in the form of the triple helix of the GBM base, which is a combination of alpha 4, alpha 3, and alpha 5. And you can see any of the genetic abnormalities in any of these 3 genes can give you a defective basement membrane. Recognized by this fraying of the lamina densa, this basket weave appearance of the lamina densa in a patient with X-linked Alport syndrome, which is, of course, dominant, as you know, compared to a normal basement membrane, as you can see. And here you have that you can demonstrate the defect of the alpha 5, or in this case, alpha 5 type 4 collagen is completely missing. This is a normal glomerulus from a normal kidney. Here you have a patient with a defect in the alpha 5, a male patient with defect in the alpha 5. Here you have also the alpha 3 type 4 is missing in these patients. And so you can construct and you can figure out what is the likely genetic abnormality just from the presentation and from the morphology. However, these days we rely heavily on the genetic testing in these patients because it is very accurate and readily available. Here is the difference between a normal GBM and a thin basement membrane. This is usually a heterologous heterozygous defect of the alpha 4 or the alpha 3, at least in males. The alpha 5 can also be defective heterozygously in women with thin basement membrane disease. So here you have the basic structural patterns that I try to discuss with you that result in hematuria and proteinuria of variable degrees with the diseases that are accompanying this. Thank you very much.
Thank you very much, Dr. Renke. Much appreciated as always. Fantastic talk. We're going to move